Assalamu alaikum. Welcome, everyone. I'm Rawa Muhsin. I'm a pathologist at the Smart Health Tower, and I'll be talking about the pathology of cutaneous melanoma. So our seniors have already discussed some of the aspects of the clinical aspects and the pathology or the pathogenesis. It's important to notice that there are two pathways to the development of melanoma. One of it has to do with sun exposure, ultraviolet radiation. So this is known as the cumulative sun damage that Assistant Professor Dr. Darsi mentioned. And this is the majority of melanomas in white populations. The second type is not related to sun exposure. So this is a non-cumulative sun damage melanoma. And this is related to mutations. So they could be somatic mutations in the individual, or they could be hereditary or genetic syndromes, chronic inflammation, trauma, or other forms of oxidative damage. We have a number of genetic syndromes that increase the risk of developing multiple nevi and also melanomas, such as the dysplastic nevus syndrome, xeroderma pigmentosa, and others. And it's important to notice that the common nevi that is present in the population do not actually transform into melanomas in the greatest majority of cases, but they may act as stimulants, meaning they are an indicator that this individual may have a higher risk of developing a melanoma in another part of the skin. So they don't actually transform, except in some cases such as dysplastic nevi or congenital nevi. So the typical melanoma histologically will have involvement of both the epidermis of the skin and the dermis. It will be an asymmetrical lesion. There will be cytologic atypia. It will have prominent nucleoli. There will be upward scatter into the epidermis. We'd have melanin. We'd have lack of maturation with depth. So this would be the typical melanoma that every pathologist and pathology resident will be able to diagnose. But sadly, that's not always the case. Melanoma is known as the great histologic mimicker because it can have variation in every single aspect of it, including the shape of the cells, the architectural growth, the presence or absence of melanin. As our seniors mentioned, that you can have a total lack of melanin in a tumor and can still be melanoma. So that's why we run into two types of problems. The first type of problem is you have a clearly malignant lesion, but you're not sure whether this is melanoma or another type of skin cancer. And the second type of problem is we have a clearly melanocytic lesion, but you're not sure whether this is benign or malignant. And we'll get to each of them. So the first problem is when you have a malignant lesion, so you know that this is cancer histologically, but you're not sure whether this is melanoma or something else because the histologic features are not typical. In this case, immunohistochemistry will be of paramount importance. This is an example of a case that we had several months ago. A biopsy was taken from a skin lesion in the cheek of a middle-aged male. And as you can see, the epidermis on top is relatively normal. It's not involved by the tumor. So this is unusual for melanoma. As we mentioned, primary cutaneous melanomas almost always involve the epidermis and extend down into the dermis, except in rare cases. So we have a dermal lesion, and it's a sarcomatoid high-grade neoplasm. So without immunohistochemistry, you cannot say what this is. You can just say this is a high-grade malignant tumor, and I requested an immunohistochemistry, but it was not performed. The patient disappeared. A few months later, about a month ago, I received the excision specimen of the same case. And again, the excision specimen was the same. So you can see this is a fascicular high-grade sarcomatoid tumor. There is extreme pleomorphism. There is even an atypical tripolar mitosis here. So this time we performed the immunohistochemistry. It was negative for epithelial markers, for keratin. I was suspecting leiomyosarcoma of the skin, but it was negative for a smooth muscle marker. And it actually turned out to be positive for the melanocytic marker or the neural crest marker SOX10. So this proved to be a sarcomatoid melanoma of the skin. Now, when I went back and examined the epidermis in the excision specimen, I saw that there are actually atypical melanocytes in the junction. This was not present in the biopsy. So this lent further support that this is actually a case of sarcomatoid amelanotic melanoma. Okay, so the second type of problem that I mentioned is when you have a clearly melanocytic lesion, but you're not sure whether this is benign or malignant because it doesn't have the typical features. Again, we have to look for every single feature in this case. If, as I mentioned at the beginning, if you have pagetoid spread into the epidermis, if the lesion is asymmetrical, if there is lack of maturation of the melanocytes with depth, if you have dermal mitosis, all of these will be helpful. So this is another case that we had. This patient had had a lesion on the finger that was removed a couple of years ago, and it was reported outside as nodular melanoma. Now the patient had a recurrent lesion at the same site. So I wanted to examine the old slides of the case to make sure that it was indeed melanoma, but the slides were not available. So now I have this recurrent lesion. The problem is that we have some atypical nests of melanocytes at the junction, so they have cytologic atypia, they are discohesive. And in addition to this, there's also some bland spindle cell proliferation in the dermis. Now, this was very difficult because I wasn't sure what the previous lesion is, and in recurrent nevi, you can have atypia. I took the opinion of several expert international dermatopathologists, and the majority agreed that this was a form of recurrent melanoma. Immunohistochemistry was not of much help, so I signed it out mostly as a descriptive report, but favoring melanoma. So you can see that it can be really difficult. Some of the people suggested that, well, it could be just recurrent atypical nevus. So it's not always straightforward, especially in a recurrent lesion. Now, as I mentioned, primary cutaneous melanomas almost always involve the epidermis of the skin and extend down into the dermis. If you have a melanoma that is purely dermal, so it's not involving the epidermis, there are a few possible explanations for this. The first one is it had an epidermal component, but it underwent regression, and now only the dermal component is left. The second one is that this is arising from an intradermal nevus, like a blue nevus. And the third is this is cutaneous metastasis of melanoma elsewhere. And it's almost impossible to distinguish the two histologically. As Dr. Dersi almost mentioned, we have a form of sarcoma of the skin, which is known as clear cell sarcoma. This has significant overlap with melanoma. The only way you can definitively distinguish the two is by performing molecular testing for the translocation, which is the T1222 for the EWS-ATF1 gene. Otherwise, histologically and immunohistochemically, it has significant overlap with melanoma. It's actually called melanoma of soft parts or soft tissues. So our seniors have already mentioned the subtypes. I don't need to mention the clinical aspects, just some of the histologic features. So this is superficially spreading. It has both a radial growth phase and a vertical growth phase. We have the lentigo maligna. This is a high CSD or high cumulative sun damage melanoma. This bluish appearance of the dermis is due to solar elastosis or sun damage. The epidermis is usually atypical, and you can see this proliferation of atypical melanocytes at the base of the epidermis. Now, where there is invasion of the dermis, that becomes lentigo maligna melanoma or invasive melanoma. Nodular is not a specific subtype anymore. It can be a variation of any of the other histologic types that we mentioned, but it usually lacks a radial growth phase. So it's just a vertical growth phase and forms a nodule. Then we have the acral melanoma. This is mostly a radial growth phase melanoma, meaning it's going along the dermo-epidermal junction, and sometimes it can be tricky to diagnose, especially in nail lesions. You have to pay attention to the detail of the cells. So desmoplastic, as again Dr. Dersi mentioned, this is a conundrum for pathologists because it's basically just a bland spindle cell proliferation in the dermis. You have to be suspecting melanoma. That's why when we have a spindle cell tumor of the skin, we always stain for a number of markers to exclude sarcomatoid squamous cell carcinoma and to exclude spindle cell melanoma. So we don't use the regular special stains anymore like Fontana-Masson. We don't use electron microscopy anymore because these have been replaced by immunohistochemistry. These may only be used in research settings. So what are the markers that we use? Well, the most common sensitive marker for melanoma is the S100 protein. This is a calcium-binding protein, and it's positive in nearly all melanomas, about 98%. It has both nuclear and cytoplasmic expression, but the problem is it's sensitive, but it's not specific, so it can be expressed in other markers. So just because it's S100 positive, it doesn't mean it's melanoma. It could be a number of other lesions. And S100 is sensitive, so for the pathologists in the audience, it's important to pay attention to the fixation of the tissue. If the tissue is overfixed, S100 can be lost. So this is a melanoma that's negative for S100. Why? Because the tissue was overfixed in formalin for a few days, and it's expressing other melanocytic markers. Now, another marker that's much nicer, much crisper that we use nowadays, we have at our lab, is SOX10. This is a transcription factor of neural crest cells. Now, neural crest cells give rise not only to melanocytes, but also to neural type cells. So that's why it's positive in both. It's positive in melanocytic cells and also in neural type cells. It's a nuclear marker, so it's very crisp and clear. This is from the problematic case that I showed you earlier, where I wasn't sure whether this is melanoma or a recurrent atypical nevus. And you can see that it's positive in both the junctional cells and also in the dermal component. It's, again, very sensitive, not specific, and it's also useful for desmoplastic and spindle cell melanomas. Then we have more specific markers. So these are related to the pre-melanosomes that are, by electron microscopy, specific to melanocytes. So this is specific, but it has lower sensitivity, about 60 to 80%. A problem in this case is that there are a number of other tumors that also contain pre-melanosomes, and this is known as the PEComa family of tumors. So we have angiomyolipoma of the kidney, we have lymphangioliomyomatosis of the lungs, we have clear cell sugar tumor. All of these also contain pre-melanosomes, so they will be positive for these markers. Another problem with melan-a in particular is that it's also positive in steroidogenic tumors, so it's positive in adrenocortical carcinomas and sex cord tumors of the ovary. The third problem with these markers is that they are not positive in the majority of desmoplastic and spindle cell melanomas. So we're only left with S100 and SOX10 for those two. So this is an example of melan-a. You can see this brown cytoplasmic expression in the tumor cells. There are other markers that we don't routinely use, but they are as useful, including tyrosinase, which is the first enzyme in the steps of formation of melanin from tyrosine. We have microphthalmia transcription factor. Again, it's a sensitive and specific marker. Now, what about the proliferation index? So you may have heard of Ki-67 in other tumors as well, such as the breast cancer, for example. So Ki is useful, but it's not a clear-cut differentiating marker. Most nevi have a low proliferation rate, so their Ki-67 rate will be less than 1%. Most melanomas will have a Ki-67 rate of more than 10%, so they have a higher proliferation rate, so it can give us some idea. Now, what about the common markers that we use in immunohistochemistry for tumors in general, such as A1A3, keratin markers, desmin? Well, the majority of these are negative in melanomas, and it can have some patchy aberrant expression of keratin, so you shouldn't be tricked by that and think that this is a carcinoma. There are other markers that I'm not going to mention because of time restrictions. The only thing that I should mention is, as I think our oncology colleague will later mention, the targeted therapies. You know about KIT and BRAF mutations. We can test for those with immunohistochemistry, but I would like our oncology colleague to answer whether they will depend on the immunohistochemistry result or actually require the molecular testing to give the targeted therapy, because we can test for those two with immunohistochemistry. So can we use immunohistochemistry to distinguish nevi, benign melanocytic proliferations, from melanoma in problematic cases? There is no clear-cut distinguishing marker, but there are some things that can help us. So those three are HMB45 that I mentioned, Ki-67, and a new marker which is called PRAME. The point is, in nevi, HMB45 is expressed mostly in the upper part of the nevus, but when you come to the lower part of the nevus, it will be lost. So there is a gradation of expression. In melanoma, it's positive both in the upper part and in the lower part, the deep part of the tumor, because there is no maturation. The same thing is true for the proliferation index Ki. We said it's low in nevi, and it's mostly expressed in the upper part, and it's negative in the lower part, whereas in melanoma, it's positive throughout the tumor, so both the upper part and the lower part. That's why I always do these two markers for any problematic melanocytic lesion that I have, in order to further help me in the diagnosis. There's a new marker which we don't yet have at our lab, but we're planning to bring it in the near future, inshallah, which is called the PRAME. This is preferentially expressed antigen on melanoma. It's negative in most nevi, it's positive in most melanomas, so it can further help in that diagnosis. A brief note about molecular findings. So in general, benign lesions, nevi, have single genetic alterations. When you get to melanomas, you have multiple genetic abnormalities. Somewhere in between, we have intermediate lesions, which are called melanocytomas, that have more than one, but not to the same level as melanomas. Now, some of these mutations can be targeted with therapies, such as BRAF, V600E, and KIT. And we can do molecular testing, again, to help us determine whether this is melanoma or benign, but this is not always the case. So there is FISH, or fluorescent in situ hybridization, for some of these. It's not performed at the pathology lab, it's performed in the molecular lab. So some points about the clinical aspects. As Dr. Dersi mentioned, there is regression in melanoma. Sometimes you have metastatic melanoma in a lymph node. You cannot find the primary because it's completely regressed. There is the term that we use, atypical melanocytic lesion or atypical melanocytic proliferation, when we don't know whether it's melanoma or benign, and we're really worried about it. In this case, what we recommend to the clinical colleague is to excise the lesion completely, but conservatively, not with very wide margins, and to follow the patient. The other point is we don't use frozen section for melanoma. It's not required. It doesn't add anything. And neither for sentinel lymph nodes, we don't recommend it. It's better to excise the lesion with safe margins, and so that we examine it routinely. Regarding spread, melanoma, most melanomas start with a radial growth phase, so they extend horizontally, and then they extend down in a vertical growth phase. Metastasis, cutaneous metastasis of melanoma, if it's a nodule adjacent to the main tumor, this is called a satellite nodule. If it's a nodule midway between the tumor and a lymph node, this is called an in-transit metastasis. These are important in the staging. So, since lymph nodes can be positive even if clinically negative, so you're examining the lymph node, there is no positive lymph node, it may still be positive. It's important to do sentinel lymph node biopsy in some cases. What are the criteria? Well, if you have a thickness of 1 millimeter or more, if you have dermal mitoses in the biopsy, or if you have ulceration, in this case it's recommended to do sentinel lymph node biopsy. We'll examine the lymph node on multiple levels. We'll do immunohistochemistry to detect small isolated tumor cells or small nests. Yeah, I'm just about to finish. So this is an example of a lymph node that we had. It wasn't a sentinel, but I brought it to highlight a point. This was from a dissection for the patient had a cutaneous melanoma. So this is a section through the lymph node. You can see that there are a lot of clusters of cells that contain melanin. So is this metastatic melanoma? No, this is just macrophages that are draining melanin pigment. You have to look closer, go throughout the lymph node, and then you see, well, there's one cluster here, there's one cluster there, and when you look at the details of these, no, these are different. They are atypical cells, they have atypical nuclei, that the texture of the chromatin of the melanin is different, so this is metastatic melanoma. So the same lymph node contained a lot of macrophages with melanin pigment, which is not melanoma, and it also contained a few small clusters of melanoma cells, which made it a positive lymph node. So finally, the prognostic factors that we can offer from the histopathology report, the most important in the AJCC staging is the tumor thickness and the ulceration. We have other features like the dermal mitotic rate, tumor infiltrating lymphocytes, and satellites. So this is the AJCC staging for the tumor category. You can see that it's purely based on the tumor thickness and the presence of ulceration. And this is for part of the nodal staging. You can see that it depends on the number of lymph nodes that are involved, whether it was clinically detected, and the presence of in-transit satellite and microsatellite deposits, as I mentioned. And thank you.
Clarifying and explaining the details of histopathology of cutaneous melanoma. Any question, please? Yes, Dr.
Thank you very much, Dr. Rawa, for this very informative presentation. About the type of biopsy, as we mentioned, as a pathologist, what type of biopsy in melanoma you prefer?
If it's a large lesion, then either a punch or an incisional would be good for diagnosis for us. If it's a smaller lesion, then just complete excision of the lesion will be better. We don't recommend shaves or curettings because we don't see the deep part of the lesion. The other two will be good.
Punches is okay. Punches is okay. A type of incisional. It is just the
yeah, but it's more tubular. The incisional is better, to be honest, because it gives us more width to the tissue rather than just depth. So we would favor an incisional biopsy.
Okay. Thank you.
You're welcome.
Dr. Thank you very much. So as a student, he was the best, and as a presenter, he's one of the excellent ones.
Thank you.
So I've got two questions. Regarding the tumor marker, you mentioned that you've got most of them, I don't know, apart from PRAME that you said
yes.
It's coming here soon. When you are going to decide which one you are going to use for the section, 1 or 2, or which one are you going to choose from the beginning, or after you take or prepare one slide and then you go for the tumor marker? And second is regarding lymph nodes. Any sort of inflammation or trauma to the lymph node can affect the presentation of the tumor cell inside this, or can give a misdiagnosis for this tumor, for the lymph node to come up as a false positive.
Okay.
Thank you very much.
Thank you for your questions, Dr. Ayman. Regarding the first point, which markers we're going to use, it depends what we're suspecting. If we have an undifferentiated malignant tumor, so we'll start with a broad panel, including just one sensitive melanoma marker, such as SOX10 or S100. When that is positive, then I proceed and do more specific markers like melan-a or HMB45. If I'm already suspecting melanoma histologically, then I'll just perform the two from the start. So I'll do the sensitive marker and the specific marker because I'm pretty sure this is melanoma and it will be positive for it. Regarding the second question, the problem that arises in assessing lymph nodes does not have to do with trauma or with, let's say, infections. Rather, it has to do with two things. One of them is the presence of macrophages in the sinuses of the lymph node, as I showed in the picture, that can drain melanin pigment, not melanoma. So we have to pay attention to the cytologic detail of the cells to distinguish them from melanoma cells. The second problem that I didn't get to mention is the presence of benign nevus cells within lymph node. So this is a phenomenon. It's been described in up to 20% of lymph node dissections. And again, we have to pay attention to the details of the cells, because if you're going to do melanocytic markers, they will be positive because they're nevus cells, but they're just benign inclusions in the lymph node. And so we have to pay attention to the histologic detail. That's all. Okay. Yeah. Okay.
Many thanks for your nice presentation. You said you don't recommend frozen section. Why? And we have a large proportion of patients with positive margin for skin cancer as general and for melanoma also.
Yes.
What do you suggest? Microscopic surgery? What's your opinion regarding this? Because that's really a big problem for us.
Yes, that's true. Well, frozen section can be performed for margins. But again, we don't really recommend it because assessment on frozen section is difficult. The quality of the slides between the images that I showed you and those of frozen section are very different. The cytologic details are very different. It can be done. We can perform it if a clinician requests frozen section for the margins of a melanoma. We can do it. But we would rather recommend that based on their clinical judgment, they just do a complete excision of the lesion if feasible. If not feasible, start with let's say a smaller excision or an incisional biopsy. Once you confirm the diagnosis, then proceed to excision with safe margins. Microscopic surgery, meaning Mohs microscopic surgery, is very time consuming. I don't think it's performed here. And it requires, let's say, dedication, a lot of time, a lot of sections. So I'm not sure if that will become possible in the near future here. But yes, you can request it if you want to perform a frozen section. We can do it, but it's not ideal. That's the point here. Use your clinical judgment and excise with safe margins. That would be better because we can better assess the tissue on the permanent sections. And you cannot do immunohistochemistry on frozen section. That's another point. So sometimes if you want to determine the extent of the lateral spread of the tumor, the immunohistochemistry will help you. It can highlight the cells. But in routine histology, that may be difficult in some cases.